And, one kind of label that we often speak about is this idea of endocrine resistance. And I'm wondering, for you when you're working with patients or you're sort of assessing a clinical situation, how do you define endocrine resistance? What features go into that specific definition and that would be important when you're picking treatments?
I think the concept of endocrine resistance is actually becoming a lot more complex, and I think there are a few different ways to answer that in terms of a definition. I think from a practical standpoint, the idea of endocrine resistance really comes down to what sort of therapies you have in hand. Do you have treatment options that are likely to provoke some degree of clinical benefit targeting estrogen, which typically comes with a lower extent of conventional toxicity? I think biologically, endocrine sensitivity has to do a lot with the underlying molecular genomic features of the tumor. Is the tumor still dependent on estrogen and related signaling pathways? And we've learned a lot over the last 5, 10, 15 years about what provokes resistance to conventional antiestrogens like aromatase inhibitors, what provokes resistance to CDK4/6 inhibitors in the adjuvant and frontline setting. And sometimes there's overlap, and then sometimes there are distinct mechanisms that drive resistance to the targeted therapy or resistance to the endocrine agent. So when I'm thinking about endocrine dependency, I'm trying to understand what is the extent of benefit the patient had on their prior endocrine therapy? What are the genomic and molecular features that I can identify in the tumor to help predict future endocrine sensitivity? But most importantly for this conversation, and when we're talking with our colleagues treating people in the clinic, what do I have in the toolbox that I think might provoke benefit either as a single agent or in a combination?
Yeah, absolutely. And I think you bring up some great points, like did the patient recur on or soon after adjuvant endocrine therapy, where we are very worried about resistance, or is this someone with a long disease-free interval or de novo metastatic disease? Were they on their first-line therapy for only a few months, or has it been years of disease control?